Hi, you're watching Hindustan Times, and I am Aditi Prasad. I have with me two top doctors today to answer all your COVID-related questions. Dr. Rommel Tickoo is Director Internal Medicine at Max Healthcare in Delhi, and Dr. Amit Thadhani is the Medical Director at the Niramaya Hospitals in Mumbai. Welcome to the show, both the doctors. We've got a huge number of questions from a lot of our viewers. And over the next hour, we're going to talk about vaccine immunity, gaps between for the first and the second dose, black fungus, steroid treatment, and a lot of other things. I'm also requesting all viewers to keep sending in your queries. We will take them live as they come in. And I want to really start with the tweet that I came across this morning from the principal scientific advisor to the government, which is Dr. K. Vijay Raghavan. And he very importantly said that whether vaccinated or not, masks, physical distancing, and ventilation, these interventions are also immediately critical for lowering pressures on the healthcare systems during this surge. Adherence is essential at the personal and community levels. Full stop by all, full stop. Dr. Tickoo, let me start with you. It seems that after masks and social distancing, now we have a third rule that people must necessarily follow to duck this virus. Clearly, this new addition, which is ventilation, is now, because of the air transmission of the virus.
Well, all along we've been saying that follow the COVID appropriate behavior, which basically was physical distancing, wearing masks, and washing hands. But ventilation also is very, very important because now there's increasing evidence that the virus can be in the air. These aerosols, when you cough or sneeze in closed environments, places where there's not enough ventilation, small rooms or big buildings where there's centralized air conditioning, the virus can be in the air for a while. And if you happen to be there, if you don't have protection, you're not wearing a mask, you can inhale the air and get infected. So this is the latest study which has come from Lancet also. And all along that we've been saying that it does remain, it's not only a droplet infection. Earlier we thought it was just a droplet infection, that if you're in the vicinity of somebody who's infected and if he coughs or sneezes and within 6 feet of distance you get it. But now there's increasing evidence that the particles do remain suspended in the air, these aerosols, which are very minute particles, for maybe half an hour to 2 hours. And if they remain suspended in the air, and if you're in a small room where there are a lot of people, closely congested spaces, small buildings, small rooms where there's not enough ventilation, so you can get infected. That's why we're seeing increasing number of people getting infected, the entire households getting infected, the buildings getting infected, becoming containment zones. We've seen that. And even now, those houses where people haven't stepped out, and they also got infected. Probably somebody has stepped out, come inside, and they're not wearing masks. And that's why now they say that you should wear masks even inside your house. If somebody, your staff or family member goes out, comes inside, maybe he's catching the infection or potentially asymptomatic, but carrying the virus can give it to you. So ventilation is very, very important. So keep your doors, windows open inside your house, even in those offices where there's not enough ventilation, centralized air conditioners are on, wear a mask. And even while having food or having your tea or coffee or whatever, be very, very careful. Avoid as much as possible. But having said that, wearing a mask is still the most important thing, I would say. And people are not doing it properly, not doing it religiously. Even now, if you see, the masks are hanging below the nose, below the cheek, and they're not doing it properly. And there's enough evidence which says that you won't catch infection if you wear the mask properly, especially double masking, which is very, very important now because this particular strain is very, very contagious. It's very infectious. So even when after having worn a mask, people are still getting infected. Doctors are getting infected in spite of wearing PPEs and masks and whatever protection they use. So it becomes all the more important. The moment you step out of the house, wear double masks and try to maintain as much distance as possible. And yes, definitely ventilation has become important now, more so since this virus tends to be in the air for a while and a lot of people are getting infected at the same time. So I would agree, apart from physical distancing, wearing masks, this is very, very important, ventilation.
So ventilation has become the third essential. There was a time when washing hands frequently and regularly was the most, was one of the three prescribed. So masking, social distancing, and sanitizing. Now ventilation seems to have replaced sanitizing. Doesn't mean sanitizing goes away. Keep sanitizing your hands, obviously, but ventilation becomes a very important part of the fight against COVID and how to keep yourself remain non-infected. Thank you, doctor, for that answer. Let's talk about black fungus. It's like it's about the new the disease which everyone is talking about nowadays, mucormycosis, and I hope I'm pronouncing it correct. It apparently invades the lungs and brains and has a very high mortality rate. What is this black fungus? And can I come to you, Dr. Thadhani, with that? And why is it really affecting COVID-19 patients?
Yes, Aditi, now mucormycosis is a common mold which is found all across everywhere in the environment. It just loves moist climate, and the common bread mold also is a type of mucor for that matter. And
Hmm.
mucor is more or less there in the environment around us. It's been around for a very long time. Now, the reason why suddenly we're seeing a lot of mucormycosis in COVID patients is mainly because these patients have received some degree of steroids or tocilizumab. We've seen it occasionally in a patient who hasn't received anything, okay, but was constantly steaming. So probably contaminated humidifiers and contaminated steamers are also one of the sources for the patient directly inhaling, the fungal spores. And fungal spores are microscopic; you're not going to see them. So, maybe if we are doing steaming at home, also you can get mucor. So, excessive steaming is not advisable, first of all. Secondly, the steamers have to be thoroughly washed and disinfected every day. Otherwise, you can transmit mucor directly by inhaling it through your own steamer. Also, as medical practitioners, it's very important that we restrict the use of steroids and tocilizumab and other immunomodulators to the bare minimum that is needed to manage the patient. Because the more we compromise on the patient's immunity, the higher the risk we are putting the patient to for getting these infections.
Let me come to you, Dr. Tickoo, with that. There was a special there's something that he talked about that Dr. Tadani said that if you even if you are inhaling or taking steam, which many of us are during these times, 2 or 3 times a day, what is excessive? What is excessive in steaming, and what could cause mucormycosis?
Well, it's only if the supplies are contaminated or the water is contaminated. It's not just the steam which can give you the infection. So, anyways, too much of steaming is not recommended. So, maybe 2 to 3 times a day. We're giving too much importance to steam and gargling. I think
Hmm.
it's fine to do it, but don't overdo things. And there's not enough evidence, actually, scientific evidence, which says that it does really help. Even otherwise, pre-COVID days also. But it's harmless, so do it, but don't overdo it. And if the supplies are contaminated, then you can get. And coming to mucormycosis, I would like to add that, as Dr. Amit rightly said, because people who are immunocompromised, they are a high risk, and it doesn't happen to every other person. So somebody who's severely immunocompromised, diabetics, and cancer patients, transplant recipients, somebody who has an autoimmune disorder, is on steroids for a long time, and then gets severe COVID. Now, COVID itself reduces the immunity. On top of that, diabetes. And then when they're given high-dose steroids, there are certain centers or certain doctors which are using very, very high dose of steroids, which is not recommended. And steroids do help in reducing the inflammation in the lungs. But apart from that, what the steroids also do is that suppresses your immunity, increases your blood sugar to very high levels, and that makes you prone for even diabetic ketoacidosis, which is a life-threatening complication of diabetes. And then when you use, along with this, you use high-generation antibiotics and to prevent secondary infection, and then tocilizumab, which does suppress your immunity and makes you prone for infection. So in this setting, you are high risk for severe infections like these opportunistic infections, especially like mucormycosis. And this has mortality of more than 50%. And the treatment is also very expensive, and even the surgery, which most of the patients need because You'll have rhinocerebral where sinuses or brain gets infected, or you can have a lung mucormycosis, or you can have skin cutaneous mucor, or you can have GI mucor. But if it's on the face, then you can lose your vision. You can have a very disfiguring surgery on your face and removal of eyes, part of the brain. I mean, it can be very, very taxing and troublesome for the patient. So, and even the antifungal treatment is long, prolonged, and even the drug amphotericin B is very expensive. So one has to use these drugs very, very judiciously. And when it comes to steroids in COVID, so one has to use them only in the second, at least after 5 days. The first 1 week is the viral replication phase. Don't use steroids during that phase. It's only after 5 to 6, 7 days that you can use it, especially on those people who have pneumonia, respiratory distress, or need oxygen. The trials, also the recovery trial in UK, gave us enough evidence that it does work wonders when it's given to people who are on oxygen or who are desaturating or have pneumonia.
Right.
On the other hand, if you give it to people who have mild disease, it can increase the mortality. So even with people who are under home isolation, if they have fever, very high fever, continuous cough, a CT showing pneumonia, inflammatory markers are high, it can be used at home, but under strict medical supervision. But ideally, it has to be used in a hospital setting with moderate to severe cases who have pneumonia, respiratory distress. So you can't start from day one, which we've been seeing. A lot of patients taking these methylprednisolone, prednisolone, dexamethasone from day 1, day 2 because the fever is not settling. But it does mask your symptoms. But on the other hand, after 5, 7 days, you get a fulminant pneumonia. So be careful.
Yeah, absolutely. And your point is very well taken. And a lot of doctors are advising against the, overuse of steroids and the rampant
That
use
is exactly
of
the problem
steroids.
with mucor. It's basically the medicines we use which can get the immunity down. And that's the reason why first week we should absolutely strictly avoid using any kind of steroids. So as Dr.
Okay.
Tickoo said, that the more we use steroids, the more you're going to have problems. The more your sugars go out of control, the more higher you are at a risk for developing problems. So the
Right.
use
And
of
this mucor
steroids has to be kept at the bare minimum.
Right, and this mucormycosis, coming back to that, it sounds really scary, and the kind of impact it has on you. And 50% mortality that Dr. Tickoo was talking about is really a huge. I mean, it's a very
So the
scary
problem, another problem with
mortality.
mucor is the high mortality associated. It's like out of the frying pan and into the fire kind of situation,
Hmm.
where we have managed to save a patient who would have otherwise died, but he's ending up with mucor, and mucor can be really nasty. It's very, very difficult, very resistant to treatment. Whichever areas are affected, you need to surgically remove those areas. The eyeball and the nose being the two common areas which need to be removed just to cure the patient. Once it enters the brain, then the mortality is extremely high. And so we need to be
Right,
very, very
sounds very
cautious to
scary.
prevent this because it's extremely preventable. It's
Right.
not
So,
as if
what precautions can
patients
patients take?
are going to get mucor. Not everybody is going to get it also. Small numbers may get it, maybe less than 1% of patients. But when it happens, it's linked to a severely high morbidity and mortality. As much as 70 to 80% of patients may not make it despite very radical treatment.
Right. So, what are the precautions that patients need to take? What are those particular steps that people can take to avoid mucormycosis? And you're saying it especially affects diabetes patients, Dr. Tickoo?
Well, your diabetes has to be under control to begin with. If it's uncontrolled, you anyway are at high risk for all sorts of infections, not only mucormycosis. So diabetic patients have to make sure that their sugars are under control, especially if they get COVID. So they have to get in touch with the endocrinologist or the physician who's sort of controlling their sugars. And on top of that, when you get steroids in COVID and you're a diabetic, the sugars do tend to go haywire. They go beyond the limits, sometimes 300, 400. So you might be on oral tablets and you might actually need insulin to control the sugar levels. But at times, steroids are indicated, and steroids are life-saving drugs in complicated severe COVID. So it's a double-edged sword. So you have to use steroids, but at the same time, you have to make sure that the sugar levels are taken care of. So insulin is something which can be used under medical supervision. Usually it's done in the hospital, but even at home. So be in touch with your physicians. And for other immunocompromised patients who are on immunosuppressive drugs, and if they have COVID, then they have to stop immunosuppressants. Rheumatoid arthritis patients are on methotrexate, or transplant recipients are on immunosuppressant drugs. And there are certain autoimmune disorders like SLE, lupus, where the patients are on steroids and immunosuppressants for a long time. So it suppresses your immunity. And if you have fever, if you're not too sure whether it's COVID, so don't wait. Don't think that it might be a normal viral infection and then we'll check after 3-4 days. So don't do that. Any fever can be COVID. And if you develop a hint of fever, then get in touch with your doctors, get it checked, stop your immunosuppressive medication. Because if you continue to be on immunosuppressive medication while you are having active infection, you are prone for severe systemic infections. You become severely immunocompromised, and then these opportunistic infections like mucor and all will trouble you. So make sure that your sugar is under control. Make sure that if you're having some kind of infection, you're off immunosuppressive therapy. So if you have any sort of infection or hint of infection, just be in constant touch with your doctors and make sure that things don't go wrong. You will still get better if you're immunocompromised, if you're treated properly, if you're not given steroids very early on in the disease. But yes, those patients who are on steroids from the beginning only for certain diseases like transplant recipients, malignancy patients, or autoimmune disorders, so we have to actually step up the dose of steroids in them. That also has to be done under medical supervision. They shouldn't do it themselves because the dose needs to be upped a little bit. So all these things can be done under medical supervision. The bottom line is be in touch with your doctors. Don't self-medicate. And if there's any sort of issue, then don't keep it to yourself. Discuss it with your doctors.
Right. There is a particular question that is coming in from Ranjit Pandey on Facebook for this mucormycosis only. And he's asking any particular food that we should be consuming or not consuming to curb the black fungus.
So there are some other immunomodulators also which are available, which are being used on trial basis. Which don't really push your immunity down as such. Maybe we should also be looking at those medications like piroxicam, Sepsivac. So other medications which not necessarily steroidal, which don't suppress your immunity as much. Those options also we have to introduce so that we require much lesser doses of steroids. Of course, they also have associated problems, but it's worthwhile to maybe a little bit of experiment with them so that we can manage at least doses of everything.
All right. Any particular food that you should be not consuming or consuming to avoid mucormycosis? Dr. Tickoo?
Yeah, I would say sugary stuff should be avoided. Go easy on the sugars because COVID patients who have severe COVID are on steroids and sugars are high. And foods, carbs, low carb diet, go very easy on sugars because if your sugars spike, then you again become high risk for these infections. Otherwise, even otherwise with COVID, have a light diet, have light meals, have a balanced diet. You can eat everything. Proteins, fats, carbs, but go easy on the carbs, go easy on the sugars and fats, I would say.
All right, let's
very
great, sir. So let's shift
questions regarding the diet in COVID, but yeah, the diet has to be absolutely a regular diet. What you've been eating at home since the beginning. You should not try to make any extraordinary changes to your diet. It really doesn't matter too much.
All right. Let's shift focus to vaccinations. Thank you, Dr. Thadhani. Let's shift focus to vaccinations, and especially now when there is so much confusion about the gap between the first and the second dose of the vaccine, especially COVISHIELD. India, of course, on Thursday announced that the gap between the two doses has increased from 6 to 8 weeks to 12 to 16 weeks. Now, lots of speculation on it.
So let's discuss about this thing. The vaccine scheduling.
Yeah, which is exactly what I'm asking.
Rommel?
Lots of speculation if the gap increases.
What should we do about the vaccine scheduling? Should it be given at 4 to 6 weeks? Or do you think it
Well,
should be taken?
they've already increased it for 12 to 16 weeks now, and it does make a lot of sense. Because if you go by the data which Oxford University and AstraZeneca provided, which was published in Lancet, I think, uh, they did show that, see, after the first jab, from 22nd day onwards, till 3 months, you get enough protection, at least 76% efficacy for the first 3 months. That's why in UK they said give it at 12 weeks, because till 12 weeks you have enough protection. After that, see, first shot just initiates the immune response. It's the second shot which is a booster. So you don't have to give it immediately. But this is only in case of Covishield. And the trials that they did in UK, Brazil, South Africa eventually showed that when the second jab is given at 12 weeks compared to when it's given at 6 weeks or lesser than that, the efficacy is much lesser. It was 56% when given at 6 weeks or before that, and it was about 81% when given at 12 weeks. So that's why, apart from the fact that they were running short of vaccines at that point of time, and they were having a bad second wave, and they wanted to protect a large population with some sort of protection with first jab, which did make sense. So now, but if I read in the papers today that they've gone back to 8 weeks now in UK.
Yeah, yeah.
So because now they have this fear of this variant, particular one which we are facing in India, might be coming there in the future, and because majority of the people there have been vaccinated with the first jab, they want to give it the second one and protect them fully. So it all depends on the condition in your country at that particular point of time. But having said that, there's enough data which says that if you increase the interval of the second jab, in case of Covishield, the efficacy is much better. The data was there earlier also. That's why we went from 4 weeks to 6 to 8 weeks, and now eventually, because we might also be having some sort of shortage, 12 to 16 weeks. But at the same time, there's data also. It's not being done irrationally. So I would agree with that. And in UK, actually, one study says that now, even with the Pfizer shot, if it's increased the time interval of the second jab to 12 weeks, the efficacy, the antibody response is 3 times more, especially in 80 and above age group. So even with Pfizer, they now say that you can increase, though it has to be validated further with more studies. But this particular study in UK says that even with Pfizer, you can increase the time interval and the efficacy is more. So I would agree with 12 to 16. The data says 12 because we can tweak it a little bit, because we also have to see our system, our population, the kind of manufacturing we can do in the coming few months. And basically the fact that we also need to cover majority of the population with the first jab, especially the 18 to 45 age group, because that's the most important age group right
But
now,
that's
which we
the
need
question.
to.
But that's the question coming up, Dr. Tickoo, because which is
So, in
exactly why
fact,
people are
just yesterday
just
night I wrote yesterday I just wrote an article exactly on the Lancet paper, which most governments consider as the authentic data for it, and it turns out that the data in it is extremely weak to justify a radical shift like this. The numbers are way too low, for actually making an honest opinion concerning the entire country. And the data is not, in fact, the article itself says that our data set is, it may be biased, it is not randomized, it was randomly selected with patient groups. So it's, when we're talking about vaccine efficacy, I am perfectly willing to say, accept that the vaccine works fine if it's given at 12 weeks. And we've seen that it works fine when it's given at 12 weeks also. It's not as if it becomes less effective or something. In fact, the efficacy continues till as much as 20 weeks also. But to say that you gave the vaccine, the first dose gives you 76% efficacy, but if you give the second dose at 4 to 6 weeks, the efficacy is just 55%, is quite bullshitty actually. Because I don't see why the vaccine efficacy should fall. And studies in the US have also said that it doesn't fall. It's fine even if you give it at 4 to 6 weeks. So that is one big, most people now with the constant changes in the scheduling have got confused as to which is the best time. If I had taken at 4 to 6 weeks, would I have I done a mistake by taking it at that time? Will the vaccine be protecting me now? These
so
constant
See,
changes have.
so
but the
what exactly are
bottom
you
line is
saying?
that you take it at 12 weeks. Bottom line is whatever 50, 60, 70, that doesn't matter. If it is more, if it's 80% or whatever, at 12 weeks, you go with that. Whether it's 50, 60, 70, doesn't, as long as less than 80, don't go with it.
So, sorry, I
Even a
just need
single
a
dose for that matter is
one second,
76%, which
Dr.
is
Thadani.
pretty
Dr.
good.
Thadani, I just want to
Pretty
understand.
good.
Can you hear my? Are you
So
getting my
single
voice,
dose at
Dr.
3 weeks or
Thadani?
4 weeks, and we've seen it. I have had relatives who developed COVID at 1 month post dose, and really nothing happened to them. Senior citizens, high risk category people who are on immunosuppressants, diabetic, and really nothing much happened to them. So in my own family, I've seen it. Even a single dose works quite well.
Dr. Thadani, are you getting my voice?
So bottom line is get vaccinated. Don't worry
I
about the
don't think
timing.
I don't think he's able to get my voice. Are you able to get my voice, Dr. Thadani? Can you hear me? Dr. Tickoo, can you hear me?
I can hear you. I can hear
Okay,
you.
I don't think Dr. Thadani is able to get my voice. But
But then
anyway, yeah,
he's answering your question.
yeah, which is exactly where. Dr. Thadani, can you hear me? Dr. Thadani, can you hear me? And I
Seems to be
don't
some
think. Yeah, so I think let them
network issue.
let them come back with that connection. But yeah, so the one of the things that Dr. Thadani raised, Dr. Tickoo, is really what I want to talk to you about. What about many people who've taken their first jab as of Covishield? Now they're wondering whether they should wait for 16 weeks because India cited real life evidence from the UK to increase the gap. But now UK shortened the window, citing the Indian variant. This has left many people confused, and probably if you'd like to shed some light on it.
Well, I would say that you're talking about the interval between
Interval,
vaccines.
yes. Yes.
Yeah. So, see, the bottom line still remains that if it's given at 12 weeks, the efficacy is better. And if it's given at 4 to 6 weeks, the efficacy is not that great. So, we would stick to 12 weeks, which the government has decided as of now. And the way things are in UK right now, because initially their aim was to inoculate majority of the population so that they have some sort of protection. Now that's what they've achieved now. Majority of the population
Hmm.
has
Hmm.
been inoculated with the first jab. Now that's why
Right.
they tweaked it now to 8 weeks, so that even if this variant reaches there at some point of time, they would still be vulnerable to this variant because if they're not vaccinated. So if they have full protection, see, having said everything about the first jab giving you enough protection, you're still vulnerable. You don't get enough protection till you receive the second jab. You're not fully vaccinated till you receive the second dose of a two-dose vaccination. So
Hmm.
first dose might give you some protection, but it's eventually the second dose which will get you through 6 months to 1 year. We don't know how long the immunity lasts. And we might actually need a booster later on also. Maybe the third shot you'll need 6 to 8 months, 12 months later, the way you do in flu. Every year you take a shot. Even Bharat Biotech is now doing a trial where they're giving the third shot also.
Right.
So it all depends on the condition in your country, how much of supplies you have, and if there is data to back it up and say that yes, the efficacy is better at 12 weeks. So why not? Why not? I would say we should have gone with 12 weeks earlier also. But at that point, since we were not short of supplies or we didn't have so many cases, and there was no need to be very, very, very aggressive. But right now, the way things are, and we have to be proactive, and to prevent the third wave from happening, from whenever it happens, if at all it happens, we have to ramp up the vaccination, because if we ramp up the vaccination now, the benefits will come then when we might be struggling with the third wave or facing a
Absolutely.
third wave. So right now, the need of the hour is to focus on drugs and these hospital beds, ICUs, oxygen, which has been done. And I'm glad now things are much better. Whether it's getting a hospital bed, ICU bed still remains a challenge in big hospitals, but getting an oxygen bed, getting these drugs which were in short supply, whether it's remdesivir, tocilizumab, now things are getting better. So we've achieved that target at least as of now, because what will happen in the future, nobody can predict. But as the virologists, epidemiologists have been saying that the third wave might hit children, because which is a
Right.
common sense, because first wave affected the elderly, second wave with the youngsters, and now children are left, and there's no vaccination for them also. And
Hmm.
so that's why we need to ramp up the infrastructure of the hospital beds for them, because as it is, we don't have too many ICU beds for children, pediatric ICUs, neonatal ICUs. So children have
Right.
to be protected. This is the time to vaccinate their parents, so that parents don't give it to their children, and children don't give it to, eventually when they go to school, they give it to other children who will give it to their parents, and this cycle will go on and on. So vaccinate the 40 young population, which is 18 to 55, and ramp up the infrastructure for the children, so that if at some point the third wave hits us, so we'll be prepared, all geared to handle it. And as far as this, there's too much of controversy regarding this interval. I think let's go with what the government has decided, which is 12 to 16 weeks makes sense. And the people who have already had COVID, I don't think they should be rushing in. They're too over enthusiastic to go for the jab right now. They can easily wait for at least 3 months because they already have enough protection to last them for at least 3 to 6 months. So 3 months, I would say, they should not even think of getting the vaccination.
All right. So for those who are planning their first jab soon, just a quick word on the efficacy of the 3 vaccines which are now available in India. There's Sputnik V, which is the third vaccine to be, approved for use in India, has an efficacy of 91%. In comparison, Covaxin is 81% effective, while Covishield now has has about 70% efficacy. But if the jabs are pushed further apart, if the doses are spaced 12 weeks apart, what we are now told that the efficacy goes up to 80%. But what about those who have already taken their first jab with Covishield or Covaxin and now want to shift to Sputnik because it has higher efficacy? Does that work?
Well, I don't think that works, and the literature doesn't say that you should mix the vaccines. If you had Covishield, the second shot should also be of Covishield. If you had Covaxin, then the second, because the mechanism is totally different. This is a viral vector vaccine. Covaxin is an inactivated vaccine. Though for the Sputnik, you can argue that the mechanism is same. It's a viral vector vaccine, but it uses different vectors for both the shots.
Right.
And there are some studies where I think they're mixing the AstraZeneca vaccine and the Sputnik because the mechanism is same. I think the trials are going on. As of now, we don't know what eventually will be the conclusion of those studies, but we don't recommend, nobody recommends as of now to mix shots. So whichever vaccine you've been vaccinated with initially, you have to take that only as of now.
Right. That's a question which a lot of my colleagues at work have been talking about openly. So I thought I should ask the doctors that question. And of course, science is still evolving, and we don't know how it actually will pan out. But there's a question coming in: women planning to conceive, should they take the vaccine now or when? Planning to conceive, I think that's that's the question being asked. If you're planning conception, should you be taking the vaccine? Can I come to you with that, Dr. Thadhani?
Yes, of course, you can take it. You would also end up transferring some of the passive immunity to the child. Yeah, of course, you must take it.
All right. There's Sangeeta Kapoor. She's asking, what is the result of Covaxin third trial? Are we vague about Covaxin? Is it not yet accepted internationally so far? Dr. Thadhani, you want to go with that answer?
Yeah, see, the safety aspect is now more or less proven. The phase 1 and phase 2 trials also had excellent data results. The phase 3, what we are seeing in the real world, whatever data was available, whatever Bharat Biotech had shared, they had also shared the preprint. It's just not published in a journal yet. The preprint was already shared, and again it shows a robust efficacy. So I don't think there are any questions on the efficacy and the safety of Covaxin as of now. And it's being sold in about 12 countries. The only country regulator which has raised a little bit of question is Brazil, and they have their own reasons for it. They've also raised questions on other vaccines. So I think there's no problem with it as such.
All right.
The latest efficacy for Covaxin, the interim analysis of phase 3 trial says 78% efficacy. Earlier they said 81%. Now they've reduced it to 78%. So average, I would say it's around 80%, which is good enough. Anything above 50 is acceptable. For Covishield, it's around 70%. There are only 3 vaccines which are more than 90%, which is Pfizer, Moderna, and Sputnik. And Sputnik has been given a soft launch yesterday. So hopefully in
Yeah,
the coming few months we'll have that too.
And also,
great.
it's also that it's a lot to do with when the trials were conducted. The efficacy. Like when the AstraZeneca trials were conducted, the pandemic was raging in Europe. It was conducted at a peak of pandemic. If showing a lower efficacy at a peak of pandemic, it's a good vaccine. Okay. Similarly, when the Moderna and Pfizer trials were conducted in the US, at that time the US did not have too many active cases for an active comparison of efficacy. So their efficacy results showed as much higher. When you look at what's happening in the real world, there isn't too much of a difference. They are all working absolutely fine. So I don't think that this we should consider one as superior and the other as inferior. They all work fine. Whichever you get, take it. You know?
All right, whichever
But
you
the
get, take it.
mutant strains are a problem with vaccines. So we don't have enough evidence to say that all the vaccines are working against the mutant strains. But with Pfizer and Moderna, there is some sort of evidence which says that it does work. We don't know because the with South African strain, the AstraZeneca vaccine did not work. That's what it was a small study which was done tells us. So as far as these present mutants are concerned, we won't again the problem is that the studies were then when these mutant strains were not around. So now to say that the efficacy will be exactly the same might be a little difficult because now you have these all sorts of mutations happening and they might skip those antibodies. These mutants, these antibodies might not be too effective against
Right.
these mutant strains. So we'll have to see how it pans out in the coming few months. And there will be more and more mutations happening. The kind of spread it has seen in India, it becomes a fertile ground for further mutations. And
And
if
as
more and
it
more
keeps
mutations
mutating,
happen, yeah, so
as
the
it keeps
chances that the
mutating, so
vaccines
will the
might become
science
infected.
keep. Exactly. So, and as you were pointing out, Dr. Tickoo, earlier, that you might have to take a shot every year and of different evolving and as science evolves, vaccines will evolve, and as the mutant evolves, I mean, it just might become a cyclical cycle, and that's the fear that many people have. But on a more hopeful note, a lot of questions coming in on vaccines. So I think vaccine hesitancy is really on the ebb now. There are people asking about if a person has recovered from asymptomatic COVID, in how many days he can go in for the second dose of the vaccine. So, which means that the person got COVID after the first dose and then now wants to go in for the second dose. Dr. Tickoo, we want to take that.
He can go for the jab 1 month after he's had COVID. But because he's had recently COVID and he's already had one jab prior, so even if he sort of postpones it by another 2-3 months, shouldn't be a big deal. So just because it was due on a particular date does not mean that if you take it a little later, then you won't have immunity or antibodies will not be formed. So if you had one shot, then you got COVID, I would say for 2 to 3 months, even if you sort of delay it, nothing will happen. In fact, the recommendation post COVID still is about 3 months. Now the government is thinking about 3 to 6 months post COVID. So you already have one shot, then you got the infection, you have enough protection for 3 months. So you just need one booster. Maybe I would say at 3 months.
Okay, one booster at 3 months. That's your answer. There's another question on vaccines. When should we get vaccinated if our RT-PCR report was positive on the 3rd of April? 3rd of April, and now we are on the 15th of May. Some say 6 weeks from then, and some say 8. Could you please give clarity? Dr. Thadhani, you want to take that?
Yeah, so I think Dr. Tickoo just answered that, that it has to be at least 1 month after the initial episode and ideally around 3 months because you are pretty well protected. 96% of people are not going to get COVID again, right? 4% is the recurrence rates. So, there's no reason to rush into it. And especially at this time when vaccines are relatively in short supply. By next month, we will have hopefully more than enough stock of vaccines for everyone because with 2 or 3 more companies stepping in. So then
Right.
I think this question will die out.
Right. So the government has unveiled a huge plan, ambitious plan from, August till December of procuring more than 2 billion vaccine doses from various companies, a list of companies. One of them is Zydus. And there's somebody who's asking, how is the Zydus vaccine? How effective do you see? Do you think it is? Dr. Tickoo, you want to take that?
Well, we don't have the data as of now. The trials are going on. So once we have the data of phase 3 trials, then we'll be able to tell how effective, safe it is. But it seems to be promising, whatever interim analysis we have of the data given so far of the phase 1, phase 2 trials. And it's a new technique. It's a DNA vaccine. And hopefully, I think it will also get approval in some time, because we are very hopeful that the data will show eventually that it is safe, efficacious, and that's what the interim analysis tells us.
Right. Let me just move on from vaccines to the medicines. And we talked about earlier, when we were talking about mucormycosis, about the use of steroids. And uh, there are random prescriptions being circulated from recovered COVID patients, urging and encouraging people to self-medicate. Many doctors are also prescribing prolonged doses of steroids, which is further leading to complications. What is your advice to your viewers? When is it okay to take steroids? When is it not okay to take steroids? Dr. Tickoo, you want to take that first, and then I will come to you, Dr. Thadhani.
Well, steroids are life-saving in critical COVID patients with severe disease, but not in mild disease. So if in the first 1 week, it's the viral replication phase. That's not when you should be taking steroids, because it can be very harmful. It will increase the viral load, increases the viral replication. So in the first 1 week, you should definitely not be on steroids. The first 1 week is about symptomatic treatment, paracetamol, or you can have the other drugs also, for which we don't have enough evidence, but still we use it to decrease the viral load, which is ivermectin, favipiravir. These are the drugs which should be used, especially for mild cases who are under home isolation, along with the vitamins and all that to boost your immunity. It's only in the second week, majority of the people will get better after 1 week, but it's only in the second week when the inflammatory phase starts, when the disease is progressive, goes from mild to moderate, moderate to severe disease, when you have lung involvement, when you are having high fever, you're coughing badly, and then your inflammatory markers are rising in the blood, and your CT scans or X-rays show a pneumonia, and your oxygen levels are dipping, your saturation is dipping. That's the point when you should be on steroids. And if given at that point of time, it can really be life-saving. There is enough data which says that, and my personal experience also says that these drugs are life-saving when given to moderate to severe cases which require oxygen and who have a bad pneumonia. So that's the time to use it. At home, they should ideally be avoided even after first week. But if there is high fever, if there's progressive disease, and there's enough evidence of pneumonia and some sort of respiratory distress, it can be used at home also, but under medical supervision, because they increase the sugars, because they can cause opportunistic infections. One has to be very, very careful. The BP can also shoot up, and there are temporary other side effects, weight gain, increased appetite, insomnia, psychological effects with steroids. So one has to be given these drugs judiciously. But having said that, they are the only life-saving drugs in severe COVID.
Only life-saving drugs. And there's still some questions on vaccines coming in, but I will take those questions in just a bit. But about medicines, there is a question that had come in earlier from a viewer. Is taking Zincobit and multivitamin daily useful in any sense, or does this cause more concerns? What is the maximum length of time for which we can take these medicines? And these supplements, are they safe enough to take for how long a period of time? Dr. Thadhani, you want to take that question?
Yeah. So there is some evidence to show that zinc supplementation helps recovery in COVID. There is no evidence that vitamin C helps. There is very weak evidence that vitamin D helps. Now, vitamins generally help when you have a deficiency of vitamins. Okay, vitamin D is deficient in a lot of urban population, as much as 70 to 80% of urban population. So, vitamin D can be given. Vitamin C also is given in virals. It's been given for decades now. It's not something new. This also being a viral, we can give vitamin C, but we don't have concrete data that it would help. At the doses in some of the prescriptions I have seen as with 1.5 grams thrice a day and 500 milligrams thrice a day, they are obscenely high doses, and there is absolutely no reason to take such high doses. Okay. If at all it has to be taken, you just take it once daily as a supplement for about 2 weeks, and that's it. You don't need to keep taking vitamins all the time because you may end up with acidosis if you take too much of C. You may end up with hypervitaminosis. There are problems associated with chronic vitamin use. So you take it for a couple of weeks during the active phase of the infection, and then you need not keep taking them. So there is very little role of continued supplementation of vitamins in the absence of any proven deficiency as such.
Okay. All right. What is the probability of getting infected with black fungus after treatment of COVID-19? And this is just talking, asking, but I have already asked that question to our doctors, but maybe somebody's just tuned in. So, Dr. Tickoo, you want to take that?
Well, it's a very,
After,
very rare. It's a very,
after
very
you
rare.
recover.
After you recover, okay. So
Yeah,
after
you
you recover,
recover from COVID. Yeah.
okay. So once you recovered from COVID, then the chances of you getting mucormycosis are very, very low. As it is, the chances of getting mucormycosis is very low because it's a very rare infection which happens when you're at the peak of your immunosuppression, when your sugar levels are high, when you're immunosuppressed, you have a bad COVID, and that's when you actually get such infections. Once you recover, your immunity has gone up to an extent, and things are getting better or on the upper side now. And I don't think that is the time when you will be vulnerable. The peak time when you are vulnerable to such infections and is when you are in the ICU, when you're having a severe disease, when you're on immunosuppression, steroids, when your disease is very, very active. Post recovery, unlikely.
All right. There's somebody asking if someone only has a loss of smell and that too 7 to 8 days and no other symptoms, is he suffering from corona and is the test necessary? I think I've become half a doctor spending time with so much with doctors these days, but I can safely say that yes, but I'll please do get the test done. But I'll let Dr. Thadhani take that question.
Yeah, so there are, let me just answer this in another way. If you don't have any other symptoms, you just have loss of smell, you can definitely still have COVID. My own daughter had a loss of taste where she was getting altered taste, and she was tested twice for COVID. It came negative. We tested for a whole lot of diseases, including all sorts of ENT problems, etc., etc. Everything came out negative, and eventually we narrowed the diagnosis down to magnesium and zinc deficiency, which also causes a loss of taste and altered taste sensation. So yes, you can definitely have COVID in the middle of a pandemic. That's the first thing you would think of, but it's absolutely not the only cause. There are many other causes for it, and if you do not have your COVID report positive, look for other causes because there may be something which you're not thinking about.
Right, and but do get the test done because we're in the middle of a
Yes.
pandemic. Do not take chances at that time. So there's another question. My son is lactose intolerant. He gets rashes and becomes breathless if he consumes milk and milk products. Under these circumstances, can he take the vaccine? I don't see the relation, but Dr. Tickoo, you want to take that
Yeah,
question?
he can take the vaccine. There's no relation between lactose intolerance and not taking the vaccine.
Right.
The only
So
absolute contraindication to Covishield is if you've been allergic to the first shot of Covishield. Other than that, if you have allergies, you definitely should talk to your doctors, but there's no contraindication. He can take.
all right. So just think of any way that you must take the vaccine because it does reduce the severity. It's not that you'll not get the infection after taking the vaccine. You will still get the infection, as we understand from our medical experts, but at least the severity of that infection will be low, and the mortality, of course, is also low after taking the vaccine. So please do take the vaccine. And can people with allergies take the vaccine? That's another question that's come in. Dr. Tickoo, you want to take that also?
Yeah, the people who have allergies can also take the vaccines, but if you've been, as I said, allergic to the first shot of a particular vaccine, then you should avoid the second shot. But other than that, if you have other drug allergies, food allergies, or any other kind of allergy, doesn't mean that you cannot take the vaccine. Yes, it's better to get in touch with your doctors or allergists and discuss it with them and then take the shot. But it's not a contraindication. They can still go ahead.
Right.
They have to tell those authorities there at the center that they have an allergic issue so that they are well prepared and geared up. And other than that, there are all facilities available. They anyway monitor you for half an hour. In case there is something which happens, they can take care of it.
There's somebody asking, can we take vaccine if you have DVT? I'm not sure what that means.
DVT is deep vein thrombosis.
Okay.
It's a clot in the legs which happens. So you should not be taking the vaccine when you have DVT, because there are certain issues with the COVISHIELD vaccine, where some studies or some data in UK showed that young women were getting deep vein thrombosis or clots in their legs. And if you already have clots, because COVID by itself can cause clots, or it's an inflammatory disease and it can lead to clots or pulmonary embolism, DVT. So you have to be very careful. So if you already have DVT, active DVT, then you should not be taking the vaccine. But if you had it in the past and you recovered from it, then there's no contraindication. With active DVT, then you have to be careful. Unlikely that you should be taking it. But again, just talk to the vascular surgeon or the physician who's treating you.
All right. Arpita Datta Sutradhar is asking, steroids plus black fungus plus diabetes. Can you explain it in simple terms, and is it curable? Arpita, I'm going to suggest to you to please rewind this video and watch our earlier discussion. When we started the video, we started with black fungus and steroids and diabetes, and the doctors have spoken at length about it. You will probably get a lot of understanding from that. But thank you so much, doctors, for your time. I don't want to take up any more of your time than I already have. It's almost going to be an hour, and I'm sure you have other things to do, patients to look at, video calls to, and prescribe more medications for people. So let me not hold you back any further. Thank you so much for your time today, and we hope to see you again on our show. Thank you, viewers, for watching, and hope this has been a helpful session for you. Thank you.